All right. Good afternoon, everyone. My name is
Hello.
Paul Dow, and I am the eHealth Innovation Strategist here at the American Academy of Family Physicians. I would like to welcome you all to our session today on virtual digital health. The full name of the session is Exploring Varying Modes of Digital Health, What Works Best for You and Your Patient Population. I would like to introduce our panelists today. We have Dr. Lisa Ide from Zipnosis, the Chief Medical Officer, Dr. Teresa Keenan from the AARP, and I add parenthetically the organization that is often mistyped when with the American Academy, the AAFP, so that's kind of hilarious and awesome. And then Jim Clement, the Vice President of Products and Services. So we'll start with Lisa and let you have a brief introduction of yourself and your organization.
All right. Thank you to Paul for moderating and to eHigh for hosting this Digital Health Equity Summit. My name is Lisa Ide. I am an ER doc by training with 10 years of emergency medicine clinical work, followed by a second residency in occupational medicine and a decade of employee and occupational health work. Today, I serve as Chief Medical Officer for Zipnosis, where I've been leading our clinical content and regulatory team for nearly 5 years, as well as our Clinical Quality Advisory Council. A little bit about Zipnosis. We are a white label virtual care platform that powers the virtual triage and visits of more than 50 large health systems across the country. Our platform supports 4 modes of care, both asynchronous and synchronous, through intelligent interviews, the async version, and then chat, phone, and video visits as well. We also allow providers to move between modes of care in the context of a virtual visit. The platform is used for virtual visits for urgent care, primary care, behavioral health, post-op, and occupational medicine, but it can be applied to virtually any healthcare specialty. With Zipnosis, patients can be treated online when it's clinically appropriate and referred to in-person care when it's needed, because we triage and route patients throughout the platform. And then we can also step up and route patients to synchronous modalities as well. So how do we use asynchronous and synchronous digital health to fit patients' different needs and abilities? I briefly have some insights from our encounter data on how patients prefer to interact with technology. We'll get into this more in detail, but in the last 12 months, 73% of visits completed on our platform were via asynchronous care, which is a trend we're very familiar with. We also saw 13% of visits completed via video. So we find that patients tend to prefer asynchronous due to its accessibility, broadband, and high speed, as well as its convenience. But video does remain a strong tool for our health systems as well. So again, providers can step up to video from an intelligent interview if needed. And just a brief overview of how we make our technology accessible, more of that to discuss soon. But one of our guiding principles at Zipnosis is that healthcare should be more accessible to all. And virtual care is an incredible place to start when you look at the increased accessibility and convenience it offers to many patients. But we know there's still gaps when it comes to who can access for virtual care. So we see accessibility as an ongoing initiative, and we are continually working to adapt and improve. A few things we've done so far that I'm sure we'll get to talk more about, but we've put in a lot of work to make our platform ADA compliant, and we currently meet some of the highest standards for accessibility when it comes to digital health. We're also putting time towards making our platform accessible for non-English speakers, starting with Spanish. And then we've done the work to guarantee that the language on our platform is gender neutral so that all patients feel welcome. And thanks, Paul.
Excellent. Thank you very much. Dr. Keenan, I would like to allow you some time to introduce yourself.
Well, thank you, Paul. And I'm very happy to be here this afternoon. And I am the Director of Health and Health Security Research at AARP. And most of you know it's not the Association for Family Physicians, where Paul works, but we do consumer-facing research on a variety of topics. And I have the pleasure of overseeing work on health-related issues, Medicare, prescription drugs, caregiving. It runs the gamut. And Paul had asked me to talk briefly about some of the work that we had done at AARP at the very beginning of the pandemic back in March of 2020, and then a follow-on survey that we'd done sort of a month later. And it just was, I guess we'll call it luck, that we fielded the survey right before the pandemic. And then we were able to follow up a month later. And we found some interesting statistics about interest in telehealth and what some of the barriers are to telehealth. We've heard a lot of those already mentioned in other presentations during the summit. But the big ones, I think, we had about a fifth of the people, 20% said they had used telehealth in the previous month, which again is very early in the pandemic. And about 2/3 of the respondents, and this is a sample of 18 plus, which you might find unusual given AARP is for people over 50, but we do sometimes do surveys down to 18 plus. And the top reason for considering telehealth was to renew prescriptions. That was mentioned by about 85% of respondents. And then about 3/4 mentioned things like helping a loved one if they were providing care, discussing a new issue with their healthcare provider, or even a routine doctor's visit. And about 2/3 said that they would consider telehealth to diagnose an illness. Now, what was interesting about the barriers that came up is we did see some age differences, which I'm sure doesn't surprise anybody. But big barriers were questions about how to use telehealth, concerns about whether there might be medical errors if their healthcare provider was using telehealth, or concerns about confidentiality of health information. And then obviously another barrier is, does your doctor have telehealth? And notably at AARP, we found that adults over 65, and I think we may hear a little bit more from some of the other speakers, adults over 65 were more likely than their younger counterparts to say they lacked access and they lacked knowledge. And so it's about 1/3 of people over 65 said that they lacked access, whether that was a computer or high-speed internet, and they lacked knowledge. And so we heard Dr. McIver earlier today talk about some of the great tools that CMS has. Obviously, those tools are necessary as we're trying to get other people to adopt telehealth services. I could go on because we do a lot of research at AARP, but again, I'm happy to be here and happy to answer any questions you might have.
You're on mute, Paul.
There we are. I was getting too excited there to look at my paper. Thank you very much, Dr. Keenan. And now we're going to hand it over to Mr. Clement from Inovalon to discuss, introduce himself and part of the technology that he supports.
Oh, thank you so much. I really appreciate you having me here today. My name is Jim Clement. I'm Vice President with Inovalon. We are a healthcare technology company headquartered in Washington, D.C. Primarily, we provide analytic solutions across the ecosystem. I specifically work in our payer business unit. We do have a telehealth offering in our provider business unit that is more traditional, more like what you've been talking about, Lisa. But I'm today going to be specifically talking about how we have used telehealth and how we continue to use telehealth in our payer business unit. So it is a narrow and specific use case, but I think it provides some good insight into behaviors and what works in the marketplace. Teresa, like you, I got lucky. I just happened to have virtual health visits on my roadmap for April of 2020. It's something we've been toying with for years. But in the middle of 2019, we made the commitment that we would actually roll out virtual visits in April of 2020. We had one national client signed up, but we're just going to start with 2 states. It's going to be a very sort of relaxed, easy rollout, do a few hundred visits in a quarter and just kind of see how it goes. And of course, it turned into complete chaos instead. Our entire portfolio shifted from the in-office visits that we would typically do, the in-home assessments, the typical assessments done for payers to close gaps in care for both quality as well as risk adjustment purposes, we very quickly had to pivot to this virtual environment. And what we discovered was that somewhere between 20 and 25% of members didn't have access. The actual self-reported number was 19%. They said, no, I don't have the capability of having a virtual visit. But I believe that number is understated, because many people would say they had the capability, but then in fact couldn't make the technology that they had work. So I think the 19 self-reported % is understated. So in my experience with telehealth going back many years, telehealth was always in many ways primarily about health equity, right? It was, asynchronous store and forward technologies, getting subspecialists out into rural areas, underserved areas, specifically in many cases targeting the underserved. I looked up in June and realized, much to my horror, that we had actually increased inequity, because there was that 20 or 25% that just couldn't get these really important services that we were providing. Our response was something we called device on demand, and we launched that in August or September. And so this obviously wouldn't work for every use case, but for these high value, important use cases for payers, we actually took iPads that were pre-configured, internet enabled, touch one button to turn it on and one button to launch. And we started getting those out to members that said they did not have the right technology. And those vastly succeeded. It took some months to kind of work out the kinks, but after about 3 months, more than 90% of the visits that were scheduled for the device on demand technology actually were completed. So in my mind, that was a tremendous success, and it was specifically servicing the most frail of our and under-resourced of our membership. So that was an interesting success that we saw. So much to talk about, but I will leave it there for now and turn it back to you, Paul, and look forward to the next 30 or 40 minutes.
Excellent. There we go. Excellent. Yes, I am unmuted there. So that's good. Fantastic. I'd like to jump back a little bit to Dr. Keenan's comment about the lack of knowledge. And certainly she can answer this question first, but everyone feel free to jump in. How do you help increase the digital literacy of your patient populations? How do you help address the folks who might only use they're a very limited smartphone, or not have internet access, or just not trust technology? I think there's a good amount of people who see things of Mr. Zuckerberg and Facebook and get suspicious of everything, thinking that it's all just one big technology bucket. So I'll let you start off with Dr. Keenan and let people jump in as needed.
I think one of the things that has happened during the pandemic is that people who have experienced telehealth have come to see its benefits and its continued limitations. So we did some additional work related to the National Poll on Healthy Aging, which is something that's done at the University of Michigan. AARP is a sponsor, and we found that over the course of the pandemic, first year pandemic, about 62% of people in a sample of people 50 plus said that they knew by June of 2020 whether or not their healthcare provider offered telehealth. So it's giving information to patients and their families about whether telehealth options are available, how they're available. Do you have to have high-speed internet? Can you have something on your cell phone? All those sorts of things. So 6 in 10 knew their healthcare provider offered it, and about half as many said that they'd had a visit. I think the challenge is, it's something very similar to the challenge that we have in research, which is, I think technology has gotten a little bit ahead of the game, in that there's still large populations that don't have access. We're going to be coming out with a study tomorrow about telehealth in rural America. And obviously lack of broadband continues to be an issue. So it's the sort of how can we deliver information to people where they currently are? And that's sort of, are they a caregiver? Are they, you know, a single person that doesn't necessarily have somebody that can help train them? Can we point them in the direction of information from CMS? I know AARP has information on its website about telehealth, but I think some of it is making connection with healthcare providers to build confidence, because one of the things that has come up in our surveys is people still have a concern that a virtual visit is not the same quality as an in-person visit. And we see that once people have the experience of a telehealth visit, they recognize that that concern falls away, right? They're less concerned about privacy because they've experienced no problems. They're less concerned about the relationship with their healthcare provider. I know that was one of the issues that had come up in a previous panel about concerns with Hispanics, like to have more of that one-to-one relationship. But once people experience telehealth and they realize some of its benefits, their concerns drop. But the concern that persists is this concern about the quality of care that's being delivered. And, you know, I'm not a physician. I'm a PhD person who does consumer-facing research. But I think that concern about quality and is the quality the same is something that has to be addressed.
I am a physician, and I'll follow up on
Okay.
that comment. So thank you for what you were saying. We focus our informatics team fairly extensively on quality, and actually have several studies showing that the quality of antibiotic prescribing is more appropriate via telehealth than it is in person. So I think as long as we continue to really focus on quality in telemedicine, it can be better, in part because of some of the tools we have built on our platform, the clinical decision logic, the adaptive interview, the information that's curated for the provider. The quality can be extremely high. And so that's an important message to get out to patients and payers, that the quality is really high. I also wanted to follow up on a previous comment about seniors, because I love that question was brought up. I think there's a misconception out there that virtual care is designed for millennials, and that really is just untrue. We actually had a 103-year-old patient access our platform and get care during the COVID-19 early days, and find that we have a fair number of seniors. In fact, in 2021, 10% of our visits were completed by people over the age of 60. And so far in 2021, we've had 10,000 visits completed by people between the ages of 70 and 90. So there are protocols. In all of our protocols, we screen out patients who are at higher risk for clinical incidents. So sometimes seniors may not qualify for completely asynchronous care, but they are able to, according to their risk level, get care on the platform. And that's really an important tool. It's so convenient for people to not leave their home, get a ride, drivers be exposed to illness in the waiting room, that we really think virtual care for seniors is going to be increasing in the future.
Lisa, if I could just add to that, I agree completely. More than 60% of our work is with the Medicare Advantage population. And so we do a great deal of work with seniors in virtual care. We had somebody that was 102 last year, but you beat me with your 103. So that's very impressive. One thing that I would say, just very, very tactically, but importantly, especially when you're getting somebody on for a first visit, it's really important that you have a very strong support team, and that support team is supported themselves with really systematic knowledge management and knowledge sharing. Because every time you take a platform and you combine it with a different piece of hardware, whether it's a phone, a tablet, a desktop, a laptop, and you've got a particular browser on it and a particular operating system on it, and you've got a particular connectivity, you've got an almost infinite number of possible ways of connecting, which means an infinite number of barriers to connecting. And so what we found is that if you get somebody on a call to connect in advance of having the provider on, to be sure that they are connected and that the individual that's supporting them really has good knowledge of, well, this phone, this model iPhone with this version OS, with this kind of browser works best with, through this process. At the beginning, of course, we didn't have that knowledge, and it took a lot of time. We would oftentimes spend 20 minutes on the phone with people getting them going. But over time, that number came down fairly sharply as we became experienced with all the different permutations of connectivity. And we cut that in half over about 6 months. And once folks have their first visit, they tend to be much more able to get on alone with their second visit.
Yes, I would say, what I've heard anecdotally from our physician members is that once you get the patient past that uncomfortable, this is different, it's not like going, the good old days of going into the doctor and reading a 4-year-old magazine, but, sitting comfortably in their own home and waiting for their turn in the queue. They're like, I'll shut up and take my money. I want to do this again. So it's intriguing. And we've also heard, the kind of, you spoke to the ramping up of the skills of the clinics from physicians who said, I did a telehealth rotation the second year of my residency for a month, and that was 8 years ago. So they had to learn new skills and integrate those into the clinical workflows surprisingly quickly. And I think that is definitely a challenge. If you're a physician, you like to practice things and be good. You don't want to innovate, or I should say improvise. You always want to innovate. It's the improvising that gets tricky.
Paul, one comment I heard from a patient last year was, I actually really like this. When I'm in my doctor's office, he spends all of his time looking at his computer. But when we're actually having our visit via the computer, he's looking at me while he's looking at his computer, and I like that better.
Yes, it feels you have that connection, that really makes it special. There's a great book I would recommend by Eric Topol, who basically about artificial intelligence, and basically it sums up into the idea that the technology will help automate some of these mundane tasks and allow the clinicians to practice deep empathy. And that's really, where it comes in. I think a lot of these things, and hopefully we'll see some of these things in kind of the remote patient monitoring, kind of making telehealth a little bit more global in its search, not just, a video link between two parties, but looking at a Wi-Fi enabled scale or a heart monitor, that is sending data up that allows trending to be documented and shared with the clinician, so they can say, hey, let's talk about this. It looks like your blood pressure's up these days, and oh, that reminds me, this is a 6-month anniversary of the passing away of your mother. So let's talk about how's the grief journey going for you, and some of those things. So it really allows the clinicians to connect on a more personal level. I guess we'll another kind of question here to think about is, how are you measuring and monitoring the results of these digital health innovations? Are you able to create studies? Are you able to say, hey, this is working, this isn't? How can we change these things and go from there?
I can tackle that one to start with. I'm curious about everyone else's thoughts as well. So we have a very strong informatics team, and we are constantly looking at our questions on the platform, on the outcome of visits on the platform. Whenever we make a major change to the protocol, we do a major protocol revision, and then we will look at pre and post data changes. But for us, one of our most helpful factors has been that we have a clinical quality advisory council. It's a group of 15 health system clinical experts across the country, and they work with us to determine the appropriate data to collect and then to review it and look at our quality and antibiotic adherence standards. So that data collection and review by outside experts has been really important for us.
Excellent. That's good to hear. I've heard some comments or some about some language modules that help expand to the scope. Are you seeing any demand, or, I guess on your roadmap, do you have, a robust set of languages, so that you can say, what, we're adding, at least 3 languages every 6 months, or things like, American Sign Language, for the deaf community and things of that nature. So, talk a little bit about, some of those pathways to inclusion, I guess would be a better way to say it, for some of this technology.
So from my perspective, there's so many factors that come into play when you build an inclusive virtual care platform. So we are continually learning and from our standpoint, and then adapting to meet the patient's evolving needs and increasing inclusivity. So like I mentioned, we do offer asynchronous care, and that increases access for those without broadband, which is a huge help. Much care can be done asynchronously or sometimes audio only, which makes it much more accessible for people. We have also focused on ADA compliance when it comes to our platform. So from a certification standpoint, we've worked very hard to become one of the leaders in this space, and we're WCAG 2.1 AA certified. We maintain web properties that are accessible for everyone in line with the Section 508 Rehab Act. And that makes a big difference for people with vision loss and certain keyboard and mouse needs. We've done audits with Accessible 360 to make sure that we are meeting the needs of people with various challenges and abilities. But this year, we've also, as I mentioned, put a lot of time into making our platform and our protocols accessible to non-English speakers, starting with Spanish. So there are 41 million native Spanish speakers in the US, and that a fully English platform may not be accessible and inclusive. So we've been doing a lot of work to translate our protocols into Spanish first, but all of the back-end work that we're doing to support Spanish will make it easier for us to add additional languages in the future. So far we're working on Spanish, but we will certainly have other languages coming.
I can add to that, Paul. Many of the same things that Lisa is saying. Our platform is nearly, well, it's exclusively synchronous work that we do in nearly, not completely, but nearly exclusively video enabled. We do a bit of audio only, but nearly exclusively synchronous video enabled. Languages, of course, are extremely important. So in addition to the audio connection, we do have subtitle capabilities built right into the platform. So for folks that are deaf or hard of hearing, we can turn on the subtitles. Currently, that is in English and in Spanish. And I believe we have gone live with Mandarin, and we have a couple of additional languages on the roadmap for the subtitles. For the audio portion, we have about 20 different languages that we support with audio only translation services or interpretation services, really. They're not yet supported by the subtitles, but everything Lisa said about making it available despite the variety of challenges one might have, variety of knowledge bases and skill sets. It's something we think about every day as we try and serve as many people as well as possible.
Excellent, excellent. Let's talk for a moment about the social determinants of health and the data that you collect via your various platforms. How do you address any blind spots that you may have for those types of data or patient populations?
So I can start a little bit. That many encounters on our platform are episodic. So our health system partners do have the option to ask segmentation questions and then move patients into an outreach queue based on their particular goals or needs within their patient population. But we provide the software and the virtual care platform for our customers, the health systems. So the access to digital health really varies by patient population. And that is why our health system partners understand their own patient population needs, and they are able to suggest the right tools or the right modes to increase access. Again, I think being multimodal, having asynchronous or intelligent chat, phone, chat, or video really addresses a lot of different population needs. So historically, async care has been more accessible, especially given varied broadband access. But that doesn't mean it's right for everyone. So we work together with our health system partners so they can address their own particular population needs.
Paul, we address social determinants in a couple of different ways. First, at the front end, we use a variety of social determinant indicators as part of our analytics. In the process of determining who needs a visit, who needs what type of visit, who needs a visit at a particular time, we do use some social determinants data in those algorithms to try and get to the right people with the right services at the right time. I think probably even more importantly, as we are capturing data during the visits, there are a variety of question sets that we go through looking for, food insecurity, for example. There's a well-validated 2-question tool to find food insecurity. So we can include some of those question sets, and we don't actually act on them, but we feed all of those data back to our health plan partners to get it back into their care management teams. And then they work to take the data that we provide to get the individuals into the right program. So we'll make a care management referral based on data that we find, connect them back to the payer team, and then they get them hooked up with the right services based on their offerings.
A quick follow-up question. What is the validated food insecurity tool that is 2 questions?
Oh, I don't think I can tell you off the top of my head, Paul, but it is a 1 question about the food that you have today. Are you confident it will last as long as needed? And there's a question about financial resources and do they exist to procure more food when the current food that you have is gone. So I'm sorry, I'm not a clinician. I know I'm butchering that, but that's essentially the tool that we've been referred to, that our chief medical officer has validated for us. Lisa, do you have any thoughts on that? Anything I'm getting blatantly wrong in that, do you think?
No, we actually don't ask that question in our episodic care when people come for a COVID visit or sinusitis visit or bladder infection visit. We address that immediate need. We have the capability to ask SDLH questions, but that would vary by a health system custom protocol particular to that health system's needs and what they're investigating.
For us as well. It's not they're not standard question sets across every member. They're customized based on payer needs and desires.
Yeah. And we've got another follow-up question there. What about addressing food insecurity when it exists for non-financial reasons? Would that fall in that scope there?
I don't think I do, Paul.
Okay. And it looks like somebody has put a link to the questions here. I will put this in the larger chat box so people can see this too. Click. So we will answer that. Okay, so
Great.
There we go. And we'll click that shut there. All right. We also have, let's go ahead. Oh, let me close participant window. Here we go. Question saying that, given the session is supposed to be on using different methods and modes of digital health, let me ask if any of you are seeing a difference in outcomes from different modes. I ask that because most of you seem to be equating telehealth or virtual visits with video visits specifically. Are you tracking and analyzing it?
From our perspective, you can go ahead, Jim.
So as I said, Paul, we complete nearly exclusively video enabled. So I would say, no, we don't have strong data on sort of the differences between audio only and video enabled. because it is our intent that 100% of our visits be video enabled.
And we are multimodal, so we do track our outcomes very carefully, but often we're combining modes. So we have very clear data on our async only. We also have direct to phone chat and video, or a patient can move between modes in a visit. So we have referrals built into the protocols. For example, someone may be doing a protocol for a conjunctivitis, and the protocol will recognize, based on clinical decision logic, that the patient needs to step up to have a video, to have someone look at their eye, or an audio call to ask a few more questions about light sensitivity. So then we'll have a combined modes. It'll start with the asynchronous adaptive interview and then go on to a synchronous mode. So we do track our adherence through that and find that the ability to step between modes is one of our key satisfiers, both for providers who have the ability to step up a visit if they just want a little bit more information, and for patients. So we're able to take care of more patients that way by combining modes. So we do indeed utilize those 4 modes of care and find greater patient satisfaction and provider satisfaction overall, because we're able to treat more patients because of that.
Excellent. Janice, does that answer your question? If we answer that, if you could just respond in the chat window, yes or no, if we want to go in more detail. Excellent. Thank you. Open it up to the group here. How are you being inclusive when you develop your digital tools? Do you do focus group testing? How do you get your product in front of a range of folks? And I see Teresa has her hand up, so we will jump right to her.
Well, actually, I had a question about just to follow up on the point that Lisa was making, because one of the issues that we've seen in our research is that people are concerned that they have a health issue that can't be resolved via telehealth, and I think they're assuming here video. So was I correct? Did I hear you correctly that you have the capability to shift somebody who's been seen via telehealth to an in-person visit?
That's correct. We route our patients to the correct level of care. So I think of healthcare on a continuum. For a simple episodic visit with someone who's in good health as a baseline, maybe they can do everything online with an asynchronous interview through an adaptive interview that's sent to a provider and back. Maybe someone needs a little bit more. They need the asynchronous interview plus a lab test. We have a zip ticket where you can add a lab test. Maybe they need an asynchronous interview and a video. We can start with an async interview, step up to a video, phone, or chat, depending on the condition and the need. But maybe they need to start with an adaptive interview, and it's clear that their condition requires in-person care. So each of our protocols refers someone at the appropriate clinical points at a protocol referral into in-person care. And when they get that referral to in-person care, we triage to the correct level of care. It may be that for the way they answered the question, they need to be seen in an emergency room immediately. Maybe they need to go to an urgent care within 24 hours, or maybe they don't need to be seen in follow-up for 1 to 2 weeks. But we have that ability to triage and route people to in-person care. And I work at a virtual care platform, and I'm the first person to say that not everything can be treated asynchronously or through telemedicine, but it's that judicious use of triage that gets people to the right level of care. People that can be cared for completely asynchronously, it's far more efficient for the patient and the provider and our healthcare system as a whole to do that asynchronously. If they need async plus a video or async plus a phone, we can do that. But sometimes you just need to come in person, and that is when it's clinically appropriate. That's the right thing to do. So our platform will triage them in through clinical decision logic with a protocol referral, but also every provider on the back end also has the ability to say, hey, we've connected via adaptive interview or via video or whichever of the modes, but I think you still need more care in person, and here's why, and they would route them to the correct level of care.
Great, thank you.
Yes, we've found it's very difficult to do shoulder injections or biopsies remotely like that. You can't send a kit and say, okay, now hold it up a little bit further and jab till you hit bone and then come back. So
although it is amazing increasingly what we can do in the home. whether it's through remote devices, through lab tests that are being sent to the home. I think that's a trend that will continue going forward. Maybe not to the shoulder injections. I don't want to do my own, but increasingly, I think we will see patients staying home for more of their care.
Excellent. Certainly, we're doing very well on time here. We'd like to open this up to questions from the audience, and we have another one here from Jim asking, "How are asynchronous telehealth visits billed?"
I can tackle a little bit about that. Each health system has the option to set the prices. So complete price transparency. When you do your asynchronous visit, if you're doing it through a particular health system, it will tell you this is $10 or $25, or for certain groups, maybe the employees of that health system, maybe it's $5. So people will have price transparency. And then there is the ability in certain states, depending on regulations and payer rules, to have that covered by the payer as well.
I know we've been approached by various vendors who have been pitching their telehealth solutions as a way to increase productivity, and their opening line is, "You're going to make so much money with this," and that's always feels like a red flag to us, at the academy. If that's really the pitch, then frankly, there's probably some other stuff here that is either questionable, and we've heard numerous times, physicians do not want to be a hamster on a wheel. They're already seeing 22, 25 patients a day. The allure of seeing 31 patients a day is not there for them.
So I don't care for the pitch that you just mentioned. I would go for the pitch of, this is high quality care. And in fact, you may get higher quality care than you would in person. And we have the data to back that up. But I will say telehealth, and particularly asynchronous care, can be extremely efficient. We have had our asynchronous visits average 89 seconds of provider time. That's after the patient may have put in 5 minutes or 10 minutes answering questions, perhaps uploading a photo if they have a rash. But because all of the documentation is done in the platform for the provider, the entire note is written. We have curated and have, through clinical decision logic, tee up the correct first, second, third line choice of medications if indicated, with red light, green light clinical decision logic built into the provider workflow. It is indeed extremely efficient. So throughout the 2020 in the COVID pandemic on our platform, we had 2 million patients treated with an average time of 1:58 seconds. So it is efficient. And some of those patients were referred to in-person care. So some of it was the triaging, but overall it is indeed efficient. And I would certainly focus on the quality and convenience to patients over another selling point.
Agreed.
So, Paul, I could comment as well.
Sure.
We obviously have a different model. Our visits are fairly extended. They average more than 40 minutes. And the biggest barrier to efficiency for our providers has been getting the member on the line, on the platform at the time that they are supposed to. So it is still it was a one-for-one scheduling. Since it's all synchronous, we had, our whole team of NPs, but one NP scheduled with one member at a particular time. And of course, you always have no-shows. And so that was a pretty material barrier in the first few months. So one of the ways that we worked around that was to begin to move away from the one-to-one scheduling model and actually be able to schedule members into a queue with a pool of nurse practitioners at the back end. So the nurse practitioners could log in and they wouldn't know exactly who they're going to see, but typically within just a few minutes, a visit would come to them and they'd get right into it. So moving away from the one-to-one scheduling to more of a pooled model and more of an on-demand model, both increased patient satisfaction, lowered no-show rates, and definitely increased provider satisfaction and productivity.
Excellent. A follow-up question from the audience. What are the logistics in Jim's practice in managing the devices he mentioned giving to patients? Do patients keep them, return them?
Well, they return them, which I think is borderline tragic. We've gone through all of the hard work to analytically identify a member that has needs, to connect with the member via a telephone call, get them to agree to a particular type of visit on a particular date and time, get them to agree to accept this device being shipped to them. We have successfully put the device in their hands, they've powered it up, they've had a visit, they like the device, they like their provider, they have 97% satisfaction rates. And after all of that good work, we tell them, now put it back in the box, FedEx will come pick it up, it goes back. We've got to find the next evolution of this, which is what's our rationale for leaving it in their hands, spending that additional dollar to leave it in their hands for all the things that we know could be happening. Various types of patient monitoring, longitudinal care. I know that there's 100 different use cases, but we haven't built it yet.
Follow-up question for Dr. Ide. What happens on the pricing transparency front when a visit is moved from one mode to another? Go ahead.
That's a pretty quick answer. It stays at the price that it started at. So if it is an adaptive interview for $25 that needs to step up to video, it stays at that $25. Often a health system who has the ability to price as they wish may price an adaptive interview at, say, $25 and a video visit at $40. That would be for a direct to video visit. So a patient knows they're starting with video. It was an only video visit. Maybe it's $40 if that's where the health system sets the price. But wherever it starts, wherever your entry point is, the visit stays at that cost.
Excellent. Excellent. Thank you. We've got an anonymous question asking for any advice on how to expand access to services in the settings of many healthcare providers having large labor force shortages. So someone's looking for a fantastically easy, well, why don't you just print more money type question. What are your thoughts on that question?
I would point them right towards asynchronous care. Again, it is so efficient. If you have a labor shortage of providers, maybe PAs, nurse practitioners, or MDs who can use a platform that is primarily asynchronous. Again, our async interviews averaged 89 seconds. They will become much more efficient and save a lot of time so that they can focus on the patients who are in person in front of them who need more time. So again, with the healthcare continuum, if someone has a simple episodic issue, that should be done in the most efficient way possible, and asynchronous care can make a big difference in a labor shortage market.
I know I've heard from physicians who are concerned that when we find solutions for them in our innovation lab, that it's going to be another website to log into, and now they have another 75 notifications to try to clear before they can consider their workday done. So it feels like it's a challenge to try to balance some of those efficiencies in ways that integrate with existing tools and existing workflows to kind of manage those expectations of the patients. The idea, we see apps, similar to the, Domino's pizza, you can see where your order is. It's in the oven, it's in the car on the way to you. And they say, well, I should have that same sort of efficiencies in the clinical settings, but it's a little more complicated. And, trying to solve, one part of the problem and make it 5% more efficient, has downstream effects that sometimes are unintended. But well-meaning technical organizations, trying to solve problems sometimes don't see the full big picture before they do this.
It is complicated, Paul, but I think you bring up a really good point, is that the expectations for patients are being set outside of healthcare. So we find that our patients are now used to depositing checks for their bank without going in person, doing it online, as you say, following the Domino's pizza chain. They're expecting this now in all facets of their life, and we in healthcare need to adapt to this. If we don't adapt in our health systems, where many providers are, it will be done in technology outside of us. So I'm sure we're all following the technology companies out there that are making vast strides in consumerism, and traditional healthcare will need to catch up or find themselves very far behind some of the technology companies.
I feel like that's its own session, sometime is, balancing, the patient. Is the customer always right? It feels like there's, some level of expectation and knowledge that has to be, some literacy, in the healthcare system, that might need to be, required there. So it feels like technology right now really is putting emphasis on lack of frictionless is the word you hear a lot, that makes it easy, for you to, just say, hey, Alexa, order me more cheese puffs. And it remembers your order, it has your credit card, and it's already processed and on the way. So the next day, they're waiting at your door. So, people have that expectation for a variety of things. And, it's interesting to try to balance those out, that we're finding, that the companies who do that well, you kind of take a step back and say, look, we can try to solve small parts of the problem, but we'll need to work together, to try to solve the larger parts. And here's those other parts, this interoperability, effort, trying to pull data from different sources, trying to push data to different sources. What do you do with conflicting information? Your Apple Watch says, one thing, but, your physician maybe hasn't diagnosed you officially with AFib yet, so you've got to try to figure out some of those complexities.
Yes, I certainly don't think we are there yet, but we're making strides in progress. And I won't advocate for instantaneous cheese puff ordering, but Teresa mentioned the need for many seniors to have an easier way to get their medications refilled. So a medication refill in a stable patient should be frictionless and easy for the patient. We have a protocol in our platform for medication refills, and it should be just as easy as going online and doing a patient encounter with all of the correct information and then being able to get that medication. That is an area that should not be hard for a patient.
Yes, we've got about 3 minutes, so we want to try to get the last few questions in here. Lisa, you've spoken a little bit about the ADA compliant telehealth. What sort, are there any barriers that have been too difficult to address, or are there any that are left undone that still need to be addressed? And of course, I'll bet to everyone on the panel as well.
Well, there's probably always more to do, but as far as the general accessibility and usability of our platform for those with differing abilities, we partnered with a company called Accessible 360 to ensure that our platform met the highest standard for accessibility. And they did an audit of our platform, and they identified issues a couple of years ago that we had not recognized on our own, like the ability to navigate our platform using only a keyboard and no mouse for someone who does not have the ability to use a mouse. And it helped us identify some gaps and gave us the opportunity to do better. That was around the time that we became WCAG 2.1 AA certified, and that is the highest benchmark for federal guidelines relating to accessibility. And this has requirements for those with motor skill limitations, vision, and more. So we're one of the only telemedicine providers that I'm aware of that's WCAG 2.1 AA certified. But that's some of the pretty deep work we did to look at accessibility for people with a wide range of abilities that needed to get care through a virtual care platform.
Excellent. And I think we will have to call it quits there. Thank you very much, Dr. Keenan, Dr. Ide, and Jim. Yes. We have 2 concurrent panels beginning in 4 minutes, driving health equity through diversity and health leadership, programs, data, and policy, and reimbursement for virtual care, a key to increasing access to healthcare for disparate communities. Participants, you can choose your next panel through the Whova app or website, depending how you're logged in. Certainly, I thank all of our speakers today. I thank you very much for your time and insights. If panelists, if you feel free to connect members with on LinkedIn if you have belief in that social media. Maybe that's the last good one. Who knows? But certainly, I look forward to further conversation. Connect with me. I'm happy to talk family medicine and innovation with anyone. We've got lots of exciting speakers, and thank you very much for your time today.
Thank you.
Thank you, everybody. Great afternoon.